Good afternoon, everyone, and welcome to DIS Engagement with Communities Experiencing Homelessness, a webinar that's part of the DIS Community of Practice for the National Coalition of STD Directors, or NCSD. My name is Leandra Lacey, and I am the Senior Manager of Capacity Building and Member Engagement for NCSD. Thanks to all of you who have joined us today, especially given all that's happening around COVID-19 response right now. As public health professionals, disease intervention specialists, or DIS, are key players in engaging their local communities for STD and HIV testing and treatment and other sexual health and support services. Today, we'll be hearing from DIS across the country about how they are successfully reaching those experiencing homelessness and linking them to services. All participants have been muted. If you have questions or need technical help during this call, please use the chat box on the right side of your screen. You can also private message me or my colleague, Tiffany Haskell, who is also a host today. All questions for presenters will be addressed at the end, but we will keep a queue, so please send them our way as they come up. This webinar is being recorded. The recording and slides will be emailed to those that register today. These materials will also be placed on the NCSD website. So for our objectives today, the webinar today aims to highlight strategies and initiatives for DIS reaching and engaging with people experiencing homelessness. You'll also hear some successes, challenges, and lessons learned when reaching and engaging with people experiencing homelessness, and just some information about local community partnerships as well for wraparound services for this population. So it should be a great discussion. So as far as our agenda today, as I mentioned, we have some star DIS speaking to you today. First, we'll have Miranda Ettinger from the Monroe County Health Department in Bloomington, Indiana. Next, you'll hear from Nicki Holm from the Multnomah County Health Department in Portland, Oregon. And then last but not least, you'll hear from Kenneth Nash from the Parish Health Unit in Alexandria, Louisiana. As I mentioned before, questions will be addressed at the end. There will be some Q&A time at the end with our presenters. So without further ado, as I mentioned, our first speaker today is Miranda Ettinger, a DIS from the Monroe County Health Department in Bloomington, Indiana. So Miranda, I'll go ahead and hand it over to you to begin today.
Great, thank you. So my name is Miranda. I've been a DIS for about 5.5 years. I also have experience working in a domestic violence shelter. I work in District 7 in Indiana, which includes 12 counties, and there's 3 full-time DIS that cover that area. And I'm based in Bloomington, Indiana, so on the map you can see I cover the green district, and then the white star is where Bloomington is. Bloomington has a population of about 85,000 people, and it's the home of Indiana University with almost 50,000 students. In 2019, Bloomington had 133 families and 243 single adults who were experiencing homelessness. We also have several hundred more people who are unstably housed who don't get counted. Bloomington has several homeless shelters and different services. And we also have some different housing programs like transitional housing. In 2018, we had a patient in Bloomington test positive for HIV who had been homeless and sharing needles with many people. We followed up with her partners, and as a result, we got 9 more HIV positive cases and tested their contacts, and we ended up testing over 200 contacts. And the majority of them were people who injected drugs and were also experiencing homelessness. So there was a lot that we learned from working with this population. One of the first things is be conscious of your location and surroundings. Our office is across the street from the Justice Building and jail, so many folks didn't want to meet with us there because of a lot of distrust of law enforcement. So we would meet folks at a location where they felt comfortable, like a friend's home, at the park, or even in our car. It also is so beneficial to get to know your local homeless populations. They can vary from town to town. So, for example, we see different infections in different parts of our district. It's important to know where people hang out, where the closest shelters are, where people may stay, where people get services during the day. And it also helps to learn local slang and nicknames. We found a lot of the folks experiencing homelessness don't go by their legal names, so it really helps to get to know nicknames. We also implemented an incentive program. So we provided $10 grocery store gift cards to people who would meet with us if they were experiencing homelessness. And this was a great way to get a lot of contacts in for testing. And when we worked with patients who were positive, we would also encourage them to let their partners know that we were giving out gift cards. We also helped with providing bus tickets and paying for Ubers and Lyfts to get people to appointments or to appointments to meet with us. Also learned how important it is to be flexible when you're working with people's lives who are pretty unstable. So we had to be willing to meet with patients as soon as they wanted to meet with us. We found sometimes if we didn't meet with patients at that moment, we may never hear from them again. And we also found that patients may miss appointments, and you just have to be patient and keep trying to get them back in because their circumstances can change from day to day. And we also had to be flexible with allowing more walk-ins because a lot of folks didn't have phones and weren't able to schedule appointments, so we had to be available when they came in. We also had to find alternative ways to contact patients. Many of our homeless patients were receiving mail somewhere. A lot of folks were getting mail at the day shelter, so it's important to kind of know where people can get mail. We also found that calling at different times of the day and different days was helpful because a lot of folks were using Wi-Fi phones that were dependent on whether or not they had Wi-Fi or if they had service. So trying at different days of the month and different times of the day, and also texting and leaving messages. We also utilize a lot of different tools for contacting or for looking up information. So, for example, we use Mobile Patrol, which is a free app that anybody can get that allows you to see who's in local jails. And when we saw that patients that we were trying to contact were in jail, we could then go meet with them there. We also use VineLink, where you can search names to see if anybody's incarcerated within your state. You can also look at court records because sometimes they'll have mailing addresses or information about a program that they might be engaged in, like a drug treatment center. We also look at marriage records to check for name changes and also social media. I would like to just mention with safety, I know this is always my mom's number one concern when I talk about my job, but we don't really have issues with safety when we work with people who are experiencing homelessness. The National Coalition for the Homeless has found that people experiencing homelessness are more likely to be victims of crimes, to commit crimes. And that's been our experience. We've never really had any dangerous situations. And if we were ever concerned, we always go out in pairs. It's also really important to advocate for your patients. A lot of our homeless patients run into barriers when accessing health care. And so we use our skills to help them access the care that they need. And it's also helpful to know your referrals, know how to access them, know how to get your patients connected with those. We work with a lot of community partners. We do have a needle exchange here in Bloomington that's through our health department, and we've worked with them to help make sure that people get the testing that they need for HIV and hepatitis C. We also have worked some with shelters to go in and offer some testing when we have some hepatitis A outbreaks. But it's also important to know how to contact shelters. Some shelters will not tell you who's staying there because of confidentiality, so it's helpful to know kind of how to get messages to people. We also work closely with our AIDS service organization, both to get people tested and to get people linked to care. We started a testing program here at our local jail. It took a lot of work with the medical staff and the jail commander and our health administrator, but we were able to set up a program where we go in once a week to offer testing. We test both contacts as well as anybody who submits a request for testing, and we do testing for chlamydia, gonorrhea, syphilis, HIV, and hepatitis C, and we've gotten dozens and dozens of cases just from doing that testing, and we do that for free, so that way inmates aren't, no inmate is excluded. We've also formed some good relationships with some of the local health departments and public health nurses in our area who have also kind of helped with different outreach and things like that. COVID-19 has put a lot of limitations on our work. We're currently not really able to do field work except on a very limited basis. We're not doing regular outreach testing, and our in-office testing is limited. We have been mailing at-home tests through the OraQuick HIV tests, but those are, of course, limited to people that have an address where they can receive packages. And another huge limitation that we see here in Indiana is the lack of affordable health care options. It can be very difficult to access state health insurance, and there still oftentimes are costs associated with that. And we don't really have a full STD clinic anywhere in our district. So there's places that will do just HIV testing or just chlamydia and gonorrhea testing. But we don't really have a lot of good options for people who don't have income or don't have insurance. Some of our next steps, once the pandemic's over, we're hoping to increase outreach testing. We've looked at possibility of testing at other jails within our district, and we're also adding a part-time staff person to help with those efforts. And we're also doing a quality improvement project to kind of target patients who use drugs and people who are justice involved, which a lot of times those two categories overlap a lot with our homeless population. So we're trying to do more outreach, make sure that they have access to services they need, additional testing and things like that. So that's all I have. I included my contact information. If anybody has any questions, I'm happy to answer them here, or you can also email me.
Perfect. Thank you so much, Miranda. If you have questions for Miranda, you can submit them in the chat box. We'll be addressing questions toward the end of the webinar. So thanks again for that great presentation. Our next speaker is Nicki Holm, another star DIS who works at the Multnomah County Health Department in Portland, Oregon. The floor is yours, Nicki.
Perfect. Thank you, Leandra. So like Leandra said, my name is Nicki Holm, and I'm a DIS with the Multnomah County Health Department. Multnomah County is situated in northwestern Oregon, just south of the Washington state border, and we're most famous for being where Portland, Oregon is located. We are located on the ancestral land of several indigenous nations, so we like to be aware of that in our work. And when we're looking at our county, we are the largest Oregon county by population, but we're the smallest by geographic size. And when you look at the Portland metropolitan region, our population actually grows to about 2.5 million, making us the 25th largest metropolitan area in the country. So we work very collaboratively with our neighboring counties. And so kind of introducing a few slides of data just to kind of set the context of, I think, why and how we've been able to prioritize this work. This region's seen growing numbers of folks experiencing homelessness for quite some time. And so the city, county, and several community partners came together in 2014 to initiate this program called A Home for Everyone. And then in 2016, they introduced this Joint Office of Homeless Services. And so with that, they've been able to kind of take a collaborative and more coordinated approach to this housing crisis we're seeing. And since those being implemented, you can see the number of folks in permanent housing options and prevention projects going up, allowing that number of folks experiencing homelessness or housing instability to kind of remain steady. as opposed to increasing. And so we work very closely with that joint office. I serve as the health department liaison for them, and we have a public health and safety call with about 30 to 40 service providers in the area once a week, and so we're in close contact at all times. Kind of looking at some rates of sexually transmitted infections in this region compared to the nation, Oregon is consistently below the national average, while Multnomah County tends to be above the national average in every category of infection. What I do want to point out, though, is in certain areas we are working with really small numbers. So like with congenital syphilis, for instance, our rate looks nearly twice the national average, but we're working with 5 cases. And so each case can heavily influence that rate. Like many places, we see an overrepresentation of communities of color in both our STI data and our data around folks who are experiencing homelessness in this region. And I think this just informs our work because people experiencing homelessness have an array of reasons for being hesitant to engage with the government or kind of having some distrust or mistrust. And these folks can also bring multiple identities that carry their own levels of trauma with that too. So being aware of the work you're doing and in the you're doing it in. And then for a while we were seeing HIV rates kind of on a decline. And then in 2018 it started to go up again. And when we were looking at our interviews and other data, we were finding that some key themes were folks experiencing unstable housing or homelessness, and then also folks disclosing substance use. Most specifically in this area has been meth use and any drug use by an injection route. And so that's kind of informed some of the partnerships and collaboration we've done. And so getting into some of our initiatives, like I said, we have a long-standing harm reduction program within our county health department that offers needle exchange services and services to folks who use drugs 5 days a week at a clinic-based setting that has their own testing ability, but then also at a mobile needle exchange clinic. And so we've been able to use our STD program to offer screening and testing services at that mobile site because a lot of our staff, myself included, have worked heavily with that harm reduction program and that harm reduction team. And then our program also purchased this testing van specific to the DIS program. And so it's ours, no one else really uses it, and it's stocked and ready to go when we need it to be. So having that flexibility and ability to go out when we need to is really nice. And then we also use an enterprise car sharing program so we can rent cars on demand and transport patients as we need to. And then our supervisors really made it a priority for our team to be out in the community every week, regardless of whether or not we have a person or a place that we promised we would be. And then this is more structural, but our DIS are attached to an STD clinic. And so we're able to vouch for the compassion and the humanity of our providers and guarantee that folks who may be hesitant to engage with healthcare, we can guarantee they will not experience the stigma and judgment they may experience in settings they've accessed before. And we can also have our providers go with us into the field to offer treatment in the field as needed. We've had a lot of successes and challenges, always learning on the way. All of our DIS are phlebotomy trained, and so we can draw blood in the field and test for HIV, syphilis, and hepatitis C. But we've also been able to use some finger prick technology. We use dried blood spot testing to test for all 3 of those, and we can do rapid HIV testing in the field as well. In certain instances, we can provide hotel or motel vouchers to house folks either for the duration of their treatment or for some set length of time. But again, that's not very frequent. And then I should have put supplies higher. I think our we don't know the needs of these folks until we actually sit and have a conversation with them. And so bringing things like fruit snacks, water, Gatorade, tampons, pads, toothbrushes is really a way to introduce who we are, why we're there, and get to a conversation around what their needs might be. And so then if they or their community could use naloxone or syringes, we have those in the field with us. And we've also developed extensive partnerships with several community partners, and so we can be there with them, make the call to the partner, and link them to that from there. Communication's always an issue. Like Miranda said, if these folks have a phone, a lot of the times it's Wi-Fi based, and so calling and texting is very limited, but getting creative with social media, like messaging on Facebook, or even using the dating and hookup apps. We've heard in certain instances that those will actually pick up Wi-Fi better than some messaging services, so it's something to experiment. But like I said, the consistent communication is a challenge. For multiple reasons, whether it's voluntary or forced in the form of like a camp removal, this population can be mobile and move around a lot. And so you could go to the same place 2 days in a row and they may not be there. And so that can be challenging. For several reasons, our priority cannot always be the priority of folks we're working with who are experiencing homelessness. There's conflicting needs, and this infection may not be high on their priority list. In some situations, we've encountered like relationship and power dynamics that have been challenging. For example, partners or communities preventing or withholding treatment. And so getting creative to get the people the services they need without jeopardizing their safety or their situation. And then also timing can be a challenge for safety reasons. A lot of folks experiencing homelessness tend to be awake during the evening and then sleep for a lot of the day. And so we can show up at a camp and everyone is asleep. And there's not really much we can do at that moment other than just be flexible with what times we go. COVID has really thrown a wrench in a lot of this. A significant portion of our staff have been pulled out to support the COVID response, and our vans also being utilized to support drive-through testing. So we have little to no ability to do this type of outreach at this point. Our clinic is also at a reduced capacity with no ability for walk-ins really. And at one point we were only seeing one patient per hour, so to limit exposure potential. But we have been able to distribute the home HIV test kits to community partners who are still able to continue this work. So I think that's where these partnerships have been instrumental. We've learned a lot in the whole process, just being a consistent face in the community and can really help to build trust over time. We've also learned a lot about identifying gatekeepers in the community, and that can look like a person who may protect the community by limiting access to them, or it could look like a service, either a shelter, a service that provides meals, your local needle exchange. If you gain the trust and respect of that person or that facility or resource, their community may start to trust you as well. And then just being really patient. Some folks may never choose to engage with you, and that's their right, but others can take a really long time, and I think just being receptive and open if and when they need you to be a resource. But these are a lot of the partners that we've had that have made this work possible. And so we've been able to take our van and park it outside of services during their meal times or just at set times during the day to offer screening. And if they trust us, their community is open. But yeah, that's all I have. I included my email on the first slide if anyone has any questions, but I'll toss it back to you, Leandra.
Perfect. Thank you so much, Nicki. Again, if you have questions for our presenters, feel free to submit them in the chat box, and we'll be sure to address all of the questions that you all have toward the end. So last but not least, we'll hear from Kenneth Nash. He serves as a DIS supervisor within the Rapides Parish Health Unit in Alexandria, Louisiana. So take it away, Kenneth.
Good afternoon, everyone. My name is Kenneth Nash, and I am a Disease Intervention Supervisor here at the Rapides Parish Health Unit in Alexandria, Louisiana. And I'd like to start by saying that there are other cities in Louisiana other than New Orleans. I know that everybody only knows about New Orleans, but there are other cities in in Louisiana, and Alexandria is one of them. We're actually called Cenla, which means Central Louisiana, because we're in the dead center of the state. The almost exact center of the state is where we're located. So it's Central Louisiana, and we've shortened it to Cenla. And what I chose today to do is to basically just focus upon our homeless coalition here in the area. It's called the Central Louisiana Homeless Coalition, and basically they work with people who are experiencing homelessness. And just a little bit about the Cenla Homeless Coalition. It was formed in 1994 by a group of volunteers, and basically what they do is they go out and they provide services for people who are experiencing homelessness at the moment. The Central Louisiana office covers 8 parishes, which is Avoyelles, Catahoula, Concordia, Grant, LaSalle, Rapides, Vernon, and Wynn. And we're in Louisiana, so we have parishes versus counties. And in this area of Alexandria, our population is anywhere from 75 to 100,000 people. And one of the services that the Homeless Coalition provides is what they call a Continuum of Care. And basically what they do is they provide funding they try to do some housing, they do some education, they do a whole wide community event in regards to ending homelessness in this region. Basically, they have several systems that they use in order to do sort of like a tracking system of our homeless people who are experiencing homelessness in this area. And they also assist with certain utility payments. They allow people to come and take showers and take part in hygiene, do laundry, and things of that nature. And they are open and they do provide services basically throughout the day and around the clock. And here also, we have a lot of people that we partner with, a lot of providers that we partner with to also help people who are experiencing homelessness. And one of those areas, one of those partners is CLASS. CLASS is called Central Louisiana Aid Support Services. And they also do HIV testing, they do STD testing, and you can walk in and you can get tested, you can request testing at any time. And they also partner with the Homeless Coalition in regards to food banks, in regards to clothing, in regards to laundry services, and things of that nature. CLASS also has what they call a balance team. And the balance team is made up of counselors, prevention specialists, volunteers, and so on and so forth with various backgrounds who come together to combat homelessness. They try to give people the tools and the skills that they need in order to move toward their values and to live their life more purposefully. What we have done here at the health unit in regards to COVID, when I reached out to our personnel here at the Parish Health Unit, there have been a significant number of people who have been experiencing homelessness present for testing. And they'll actually come and say that they don't have an address at the moment, they are experiencing homelessness at the moment, but they still request testing. And they don't have to have an address, they can just come in and they can just be tested like any and everybody else. We also have certain services now with the COVID pandemic that's going on. Well, we have the Fast Track. And Fast Track is where you can register ahead of time, and it gives you little to no waiting, allows you to move through the line more expeditiously. And there's also an area called surge testing, which is where you can be tested with extended hours, including on Saturdays. And they have recently started that as early as this week. And this is just one of the brochures that they have enlisted in regards to the COVID response. And it's go get tested, and it's go for, that's our slang for go here in Louisiana. And it basically gives you information on what you need to do, what you have to have in order to present for testing, certain things that are required, certain things that are not required when you do want to come in and get tested. Again, it says you don't have to have an address, that you don't have the signs or symptoms, and things of that nature. And it's also one that on the other side is in Spanish, because here in this area we do have a pretty large population of Spanish-speaking people or people of Hispanic descent. If people are interested in being a volunteer with the Cenla Homeless Coalition, this is some of the things that they can do. They do have what they call foot soldiers, people that actually get out into the community. They do street outreach. They also do volunteer. They're boots on the ground. They go out and they find people who are maybe living in shelters, or in this area we call, some other areas are called tent city, where a lot of the homeless population or people who are experiencing homelessness, they gather. And they also offer testing, they offer clothing, they offer food, they give them things to use for blankets and when it's cold outside and things of that nature. The outreach activities are more popular, and it's a very popular form of volunteering here. And what I have found is that there are a lot of younger people in between the ages of maybe 18 to 25 that actually volunteer and go out and see what they can do to combat homelessness. I guess the CEO of the Homeless Coalition is Joseph Busetta, and this is his address here, and he does a lot of outreach, and he does a lot of community involvement in regards to combating homelessness. These are just some of the volunteers that we have in the area that give their time, they give their effort in regards to how to combat homelessness. These are some other volunteers, and basically they go around the city and they go from place to place. Wherever they think that the tent city has gathered, they'll go there and they'll try to reach out to those individuals who are battling homelessness or people who are living with homelessness at the moment. And I do have some statistics in regards to our STD rates. I know in 2018, Region 6, which is where I am in Alexandria, we had the 8th highest number of chlamydia diagnoses and the 6th highest diagnosis in the state of Louisiana. And in 2018, we had 30% of chlamydia diagnoses were in this area alone, and they were among males. We do have a racial disparity where we have a higher number or higher percentage of African Americans testing positive as opposed to any other race. In 2018, Region 6 had the 7th highest number of gonorrhea diagnoses and the 4th highest rate in Louisiana. Again, that is in this area. In 2018, Region 6 had the 3rd highest number of primary and secondary syphilis and highest diagnosis rate in this area. And we do go out into what we call field visits. We'll go out into the area and we will try to come across people that may be experiencing homelessness that have probably been on our contact list and our task list, that we'll try to reach out to these people. We'll try to offer them testing. We will actually go and pick them up and we'll get them here, anything necessary to basically take care of them and allow them to achieve and maintain a healthy lifestyle. Back in regards to COVID, we actually had a COVID meeting on July 16th in regards to with the Healthy Initiative Coalition, where our Dr. Holcomb, who's our medical director of Region 6, he spoke in regards to COVID in Louisiana and how you don't have to have symptoms, you could be asymptomatic. He explained how masks are very effective in reducing the spread and that everyone should be wearing masks unless they have medical reasons to prevent them from not. He talked about social distancing and the importance of social distancing and how children, even though some children may not get ill from the virus, can sometimes show no sign and still yet transmit the virus to maybe older people in the home or in the community. He also gave a percentage where 50% of the people do not call or answer the phone when it comes to their testing, so they have not been in close contact with anyone in the past 2 weeks. Dr. Holcomb also stated there is a plan in place to start having testing in schools for staff and kids to prevent an outbreak in schools in this area. So basically we have a lot going on in regards to the COVID, in regards to people experiencing homelessness, and our goal and our job here is just to have people achieve and maintain a healthy lifestyle as best way as possible. And we're just there to be the middleman to make it happen. And basically that's kind of what I have.
Thank you, Kenneth.
You're welcome.
We appreciate you giving your perspective from Central Louisiana. So before we jump into Q&A with our presenters, I'd like to be sure you all are aware of the DIS Slack workspace that NCSB has. So Slack is the communication platform for our DIS community of practice, where you can chat with DIS across the country and share resources on any topic from field safety to technology and partner services. We've also created a coronavirus channel so you can easily find and share resources related to COVID. If you'd like to join Slack, you can use the link that is in the slide deck. Tiffany will also post it in the chat box, and it's also listed in the web links box as well on the bottom left-hand corner of your screen. In that web links box, you'll also see a link for the NCSB COVID Command Center that houses a ton of resources for you and your STD program. There's also a survey in this web links box that you can fill out about your area's DIS COVID response, which will help NCSB in phase 2 of getting a clear picture of where STD programs stand with their capacity in responding to COVID right now. So just wanted to make sure I plug those various resources, make sure you knew where they were. You can click on those if you're interested. So now we'll take questions from the chat box for our speakers. Feel free, as we're chatting, to continue to submit your questions in the chat box while we're talking. So the first question came from Jillian. Jillian asked, I believe, Miranda, this was for you when you were speaking. What kind of activities do you incentivize? Is it interviews, treatment, partner elicitation? What kinds of activities do you incentivize?
So yeah, we incentivize all of those. If a patient is a contact, we usually will give them one gift card for meeting with us for testing, and that's meeting us anywhere, in the office or a park or wherever. And then if they test positive for anything, we usually give a second gift card when they come in for a treatment appointment or if they come in to do an interview with us. We've also done some impromptu testing within a housing unit that's for people who are formerly homeless. And a lot of people who are currently experiencing homelessness will stay there sometimes. So we've also gotten calls from residents there to do testing, and we always try to give gift cards to everybody who does testing when we go there to do testing. And that's just to kind of help build rapport and encourage people to, feel comfortable with us and, gives them an option the next time they do testing. That way they know where to go. But they're just $10.
Great.
Yeah.
What was that? What was the last part of what you said?
Oh, they're just $10 gift cards, and we buy them in bulk. So,
Okay.
we do it pretty liberally.
Okay, gotcha. Nicki and Kenneth, do you all have a similar system set up? I don't know if you mentioned this in your presentation, but do you all have some kind of incentive system as well set up where you are? Just as a follow-up.
Oh, well, this is Kenneth. We don't have it at the moment, but it is something that we have been talking about when we do meetings, especially in our STD task force. We had talked about some incentives and things of that nature, and I do think that it's something that we will probably get on board with once we get past all the corona stuff. So it is something that we have talked about in our area.
Okay.
Yeah, and Miranda, this is Nicki. We've talked about doing like smaller gift cards to incentivize testing, but we haven't really done that on a larger scale. We have done, when we started noticing our rates of HIV go up, and the Oregon Health Authority really did this, implemented an enhanced interview, which is kind of like an added-on interview. And if folks who had recently tested positive for HIV completed that interview and had that conversation with us, we could give a $50 gift card just to better understand some questions that Oregon Health Authority wanted to look at. And then in certain situations, we can incentivize treatment completion, but it's not, I wouldn't say it's across the board.
Okay. Thanks, Nikki. Our next question comes from Ashley. Ashley, Miranda, this question was also posed toward you. Toward the end of your presentation, you did mention some quality improvement events or initiatives that you have planned. We'd love to hear a little bit more about those particular initiatives that you have planned for quality improvement. Can you talk a little bit about that?
Sure. So we're focusing on one county in our district to start with, where we've been seeing high rates of drug use and a pretty steady increase in gonorrhea cases. So we're focusing on folks who test positive for gonorrhea and then looking at court records and kind of dividing people up into categories based on what charges they've gotten, like drug charges and things like that. So we're going to try to do more interviews. We found a lot of these folks we weren't interviewing for kind of a variety of reasons, but we're going to plan to make them a priority, make sure that we link them to additional testing for HIV, hepatitis C, and syphilis, as well as eliciting more partners. And this may kind of as like a part two to this project. We may also use this to advocate for more jail testing and outreach testing within that county.
Great, thank you. Let me put it back on our slide. There we go. So the next question is Bianca. Hi, Bianca from West Virginia. She asks, how exactly have you been able to build bridges with shelters, especially while maintaining confidentiality? And this is the question that I'm also interested in. Just thinking about how you build rapport, build trust, with homeless shelters. Can you all speak to that a little bit?
Well, I just like to say first, I think it was Nicki, this is Kenneth in Alexandria. I think that was Nicki that spoke, and what she spoke about was building trust. I think that makes the biggest difference in regards to how you build bridges with people that are experiencing homelessness. Because what I have found, at least here in this area, when the people that are experiencing homelessness, they are dealing with mental illness, they are dealing with drug addiction, they're having domestic violence issues. The last thing they're trying to do is come to the health unit to get tested in regards to particular STD. What they're trying to do is figure out, where am I going to sleep, where am I going to eat, and where am I going to get high for the next day. And I think when we build that relationship with trust with them, I think that lets them know that we're on the team with them, that we're here to help them, to come out of the situation.
Thanks, Kenneth. Any other feedback from Nicki or Miranda on, maybe strategies that you've used to build trust and build bridges, especially when it comes to shelters and maintaining confidentiality?
Yeah, this is Nicki. Definitely emphasizing what Kenneth said is really important. Our position within that Joint Office of Homeless Services and really being integrated with a lot of other community organizations has positioned us well to get to know them over time. And so I think we've had the most success with day shelters who have let us come bring our van, park outside, and they refer people who trust them as a safe place to be. They refer them to us outside, and so that's, for some people, that's our first interaction with those folks. And so I'd say the day shelters we've had most success with.
Great, thank you for that input. Let's see. The next question that we can address is from Parissa. Parissa asks, she'd love to hear more about experiences with linkage to care for HIV. with folks who are experiencing homelessness. Can you all talk a little bit specifically about, if you have a linkage to care system and how that works and how that's working out for you all when it comes to working with this population?
Okay, this is Kenneth again. I think that we have a good team in regards to linkage to care. We have a facility here that's called the Two-Lane CD4 Clinic and class, which is part of my presentation, Central Louisiana Aid Support Services. And those two facilities are who we link HIV-infected people with, and they provide them with everything needed in regards to medicines, in regards to their doctor visits, lab work, and everything. And basically all we tell the patient is all you have to do is just show up. Even if you can't get there, we can get you there. We have transportation vouchers and things of that nature. So we haven't had much issue in regards to the linkage to care. I think we do a pretty good job on that one.
Yeah, and this is Nicki. I think in Portland, we're kind of uniquely positioned. Our DIS team is situated within an STD clinic in the health department headquarters, and we're on the second floor, and on the third floor of our building is a clinic called the HIV Health Services Center. And so if we have someone in our clinic test positive, or if we're trying to bring someone to our clinic, we can literally walk them upstairs and do a warm handoff with a clinic who is a primary care for folks living with HIV and hepatitis C. And so that close partnership and relationship and knowing that clinic staff really well has been invaluable to us.
Great, thank you. Miranda, do you have any input there from your perspective?
We have a really, really strong relationship with our care coordination program here, and they have a linkage to care person who is willing to, help with transportation and rescheduling appointments over and over again. We also have kind of an arrangement between our care coordination program and our local jail nurse for when someone is in jail and they're not in care. We all work together to make sure that person gets in care if they need it, or gets their medicine if they are already in care. So it's a lot of kind of making sure we're all on the same page, but that's been one of the best ways to get people in care, is being able to contact them like once they're incarcerated.
Thank you for that input. Let's see the next question. So LaShonda had a follow-up about, developing those relationships with homeless coalitions and shelters. I hope we answered that for you, LaShonda, earlier. The next question we'll take is from Pike, who's really hoping for some creative ideas for how to continue testing and treatment in spite of COVID. Are there any ideas that folks are considering? So, Kenneth, Miranda, and Nicki, I'll kind of put that over to you, and others in the chat box, you're welcome to type in ideas that your jurisdiction is also thinking about in making sure that folks have the testing and treatment that they need in this new era of COVID. This is something that NCSD, internally is also working on as well, and thinking through how we can support our members in continuing these services. So, any input, Kenneth, Miranda, or Nicki?
This is Miranda. Our testing has been cut back pretty significantly. I'm still working remotely just because we have limited space in our health department. We are attached to a family planning clinic, and they have started seeing people again, and they have a lot of they're using a lot of PPE and have put up like plexiglass barriers and things like that. So we have been able to get patients in through that clinic. But our testing has been cut back pretty drastically. We have also tried to keep up to date with what other places are offering testing, whether that's a walk-in clinic or an FQHC, and being able to give referrals and things like that to patients.
And this is kind of just to kind of piggyback on Miranda. We are basically doing a lot of telemed appointments where we're calling in prescriptions for patients and for their contacts, and we're also referring people to the local urgent cares here in the area, and they have been working with us in regards to seeing patients and getting patients in, because we do have a good provider relationship with different areas, different providers in the area. So we do a lot of referring over to a lot of the urgent cares and so on and so forth.
Yeah, and this is Nicki. So our clinic is slowly increasing its capacity to see and treat patients, but we are doing some telemedicine appointments. We have been able to purchase the OraQuick at-home HIV test kits and deliver those to people who reach out to us and need them, or we've been able to distribute those to, there's an organization here called Portland Street Medicine, and it's a retired emergency room physician who drives around in a Sprinter van and offers health services to folks experiencing homelessness. And so we have a close working relationship with them, and we've gotten them HIV test kits to kind of continue this outreach while we can't. But then we can also deliver treatment to folks who may not be able to make it in person to our clinic, as long as that's like an oral medication.
Great, thank you. Jenna had a question. Hi, Jenna, from Fresno, California, asking, saying they would like to hear more about the home HIV test kit program. How are you confirming test results? Is anyone using 3-site STD testing? So Kenneth, Miranda, or Nicki, you can speak to this if you have knowledge of this, or others in the chat box that are participating today on today's webinar. Feel free to also chime in the chat box.
This is Miranda. We've been doing the testing kits. They are already packaged up nicely with instructions and all of the supplies for the oral swab. We mail them along with kind of some information about the test, as well as how to contact us with results. We ask that they call or text us. We don't always get results from people. Sometimes, you know, phone numbers change or they just don't want to get back with us. But for the most part, we do get results back. We have not had any positives yet, and we did just start this program within the last year, so we haven't had any positives. If we do, we still meet with them for blood tests. We still will do that confirmatory test, and that's kind of how we've worked it out. And the kits are really thorough, so we don't have to do a lot of work, but we also make sure that patients know that we're available if they want to call or text while they're doing the test if they have any issues.
Yeah, and kind of similar to Miranda, when we're delivering the test kits, our providers are happy to do a telemedicine appointment while the person is doing the testing themselves. And then if they report any positive, we'll see them pretty quickly in our clinic setting to run any confirmatory testing that's needed.
Awesome, thank you. And speaking of at-home testing, so NCSD has done quite a bit of work around at-home testing. We've done several webinars, and we have a technical brief. If you are interested in learning more for your jurisdiction, I'll go ahead and paste that link into the chat box where we have all of those resources. If you want to check it out, if you want to share it with your colleagues, because I know that there's a lot of questions these days around at-home testing, given that we're in this new era of COVID, and how do people continue to provide the services that folks need. So I will put that in the chat box for anyone interested. Are there any other questions for our presenters as well? Feel free to put them in the chat box. And we'll give everybody a second. Thanks for pasting those links as well, Nicki. I see that you're putting those in the chat box as well for some programs that you mentioned.
Yeah, of course. Thank you.
Yeah. I have a question while we are waiting for some folks if you are typing in the chat box. Nicki, I think you mentioned in your presentation that sometimes the folks that you're engaging with say that the apps that they're on, dating and hookup apps, often have better like Wi-Fi signal or service for you to reach them. So can you talk a little bit about how, are you using those apps to reach people? If so, how? Like what strategies are you using in this online venue to reach people? Because I know it can be a little bit different reaching people online as opposed to in person. Can you talk a little bit about that? And if you all are doing that at all, or if it's just an anecdote that you were mentioning?
Yeah, so in certain instances when we're talking about partners, some people will have no information other than the like Grindr profile for a person per se. And so they'll share with us that, and we're happy to reach out to people that way if that's their only mode of communication. And I interacted for a while with this one client who said their phone didn't receive text very well, but that their messages came through Grindr very, like a lot better. And so that was kind of a good tidbit. I don't know if that's across the board or what a lot of people would say, but at least in that situation, that communication was more reliable than messaging on a texting service.
Okay, thank you. Any other questions from folks? I'll give it a second. And if not, we can go ahead and wrap up. This was really, really, really good. I'll give folks a second. Well, with that, I want to say thank you, everyone, for joining today. Thanks again for our wonderful speakers, Nicki, Miranda, and Kenneth, for your perspectives from your various jurisdictions. It was super enlightening and informative. I would encourage everybody to please complete the evaluation after the webinar has ended in order to inform future NCSD webinars. Tiffany has posted the evaluation link in the chat box, and it's also listed in the web links box. You'll be automatically directed to the evaluation once I end the webinar as well. The recording of this webinar and the slides will be emailed to all of those who registered, and they'll be posted on the NCSD website, so be on the lookout for that. If you have additional questions for the speakers today or for me at NCSD, our contact information is in the slide deck, so feel free to reach out to us. And with that, have a wonderful day and stay safe, everyone. Take care.